respected chairpersons and dear friends. Being a doctor and to be among techies is a new experience. I'm basically here to share my experience with particular technological advance happening in the field of interventional cardiology called OCT, which is a light-based imaging system. We cardiologists look into the coronaries and put a stent to remove the blocks. We make use of this particular device I will take you upon. At the outset, I thank CAHOTECH 2019 for giving me an opportunity to be a speaker. And at the same time, I thank my chairman and head who is heading my hospital. I'm working in a hospital called the Meenakshi Mission Hospital in southern Tamil Nadu, a place called Madurai, which is 750 bedded, and I'm there for more than 20 years now. And being a doctor and a son of a famous urologist, he is always ready to invest upon newer technologies. One such technology which we are the South Asia first integrated system of OCT to have, and we are working on this for the more than 2 years now, and now I do most of my angioplasties with this OCT guided. I can say my penetration of this device in my day-to-day practice is almost 90%. Without wasting much time, I'll move on to, I'm going to deliver this talk on this following contents. Review of system and catheters, how this system is being interpreted by a doctor, image orientation, image interpretation from simple to complex, various morphologies, and the stents which we are going to put, how we can interpret them, and the comparison between this light-based imaging against sound-based imaging. We all know that that's the one we started with, intravascular ultrasound. And artifacts are always a part of technological advances, how one can identify that, and few fundamentals. And finally, I'll finish off my one clinical case, which I did very recently. This is a system overview. This particular light-based imaging system basically started in the early 90s in ophthalmology, where the physician used it in retinal detachment, from which we cardiologists picked it up. It is basically from a source, light is being delivered to a structure. When the light hits on a structure, it gets reflected back. Depending on the texture and the penetration of the light, the structure will give back the reflections to the source again. The source will give a pattern by software interpretation. Those patterns will be read by the physician as a normal or abnormal, depending on which he is going to implement his therapy. That is how it is very simple to put it. And it has gone through various advances from 2009 to till date, from time domain to frequency domain. And presently, which we are working with in my lab is Optis integrated co-registered with angiogram. I mean co-registered is, moment I take a cine of my coronary angiogram, when I pass this light into the coronaries, wherever the light goes, there will be a white dot marker which will be correspondingly coming in my angiogram. My angiogram and this light-based imaging both are registered so that I can exactly interpret the site of interest as I interpret in the my coronary arteries by the angiogram. Not only that, it is integrated to my lab. That means instead of seeing it in a different console which moves everywhere, I can see it right away on my panel, like how when I put a stent, how I see the coronaries. Similarly, I can see the particular imaging of this particular technology also. This is basically a catheter which has various markers, which is connected to a console from where the light source is being, it's a light source called near infrared light, which is being delivered. And we have two kind of delivery modes, and you get the pullback. We need to clear the blood from the coronaries by a 14 ml of dye, which is supra density than the blood. So when you push it, because blood is a big hindrance to the light. When blood comes in between the light to the structure, you are not going to see the structure. So you need to push a dye contrast, which we routinely use for angiogram. Those dye will push the blood away from the structure so that light can really go and hit the structure and come back, and it will give a pattern for the physician to interpret. And it will be, this is what I mentioned, there is a white dot coming in the angiogram, that's we called as co-registered, that corresponding white dot telling you the short axis, and there is an automatic lumen profile in between. The automatic lumen profile is something equivalent to 360-degree spin of the coronary at 0.2 mm intervals. This is something a clinician, when he does an angiogram, he has to look into the artery, side, back, front, oblique, all that. But when you're going to use this particular modality, it gives an average of 360-degree spin. That means one angiogram is going to give multi-projection angiogram. That means the doctor is going to spend little time in the lab, going to use little dye, and the same token he is going to see the arteries and different projections. And finally, the lowermost mode is a longitudinal mode. And this is the image orientation to quickly go through. Basically, the light, when it hits a structure, when it comes back, it will come back as a signal rich or signal poor. And depending on the light, able to pass through the structure. If the structure is allowing the light to penetrate, and if you are going to see the structures behind, it will be low attenuation. If the structure is not allowing the light to go beyond that, it is high attenuation. And the structure closer to the light and away from the light, depending on these characters, we are going to interpret the images. Like here, there is a camera inside, and you are seeing a dark lumen where it was filled with blood being removed by contrast, so the light was able to hit the wall of the artery. And closer to the wall, you are seeing a darker band, which you call it as intima. Then next lighter band, which we call it as media, and another band, which is called as adventitia. Any artery made up of 3 layers, intima, media, and adventitia. Light having thrown on the coronaries, fantastic picture, we call it as golden tube. You are able to see this triluminar structure. This is something like cutting a coronary artery specimen, putting it in microscope, and how you will be seeing the structures like that you are going to see. And their next advance will be micro OCT, where this is up to 10 microns we are able to see. Intravascular ultrasound was able to show structures to the definition of 100 microns, whereas OCT came to the 10 times better than intravascular ultrasound to the level of to the resolution level of 10 microns. Micro OCT is going to come to 1 microns. That means you are going to use these modality like a microscope inside the arteries. And this is another mode and to form. These are the big 3s which we come across as pathology in coronary arteries: fibrous plaque, and lipid accumulations and calcium accumulations. I will tell you how we are going to see them in when you pass these slides. This is how the normal artery looks like, which I said earlier. As far as the intima is 0.5 mm in thick, there is no lipid accumulated. And once there is a calcium, where is a signal poor, light is able to pass through, there is a lower signal, and there is a sharp borders around, so you call it as calcium, where there is an arrow, yellow arrow is pointing. And then another type of fibrous plaque, which is the commonest plaque pattern, the mode of block which happens in any human arteries, where it is signal rich, but light is able to pass through. And the third one is lipid, which is the commonest cause someone gets sudden heart attack. It is because of the soft lipid accumulation over which there is a fibrous cap which breaks, and the lipid comes into the blood, where the platelets form a clot, and that is how you clog, you get a heart attack. So out of the 3, the lipid plaque is the most dangerous plaque. How the light going to show it up? You can see that's like a toasted cake. There is a low signal, but light is not able to pass through. There's a signal drop off. So this is how you see, and this is how been defined. And once you come out of the wall, when you come to the lumen, yesterday I did a case, when I put a stent, at the proximal part of the stent, there was a clogging of the blood. Red thrombuses were forming right in front of my eyes because of the edge crack. So it was clearly shown by this OCT, light-based imaging. So I could save the patient by putting an additional stent at the proximal edge. This is white thrombus, again, an old form of clot, where it is signal rich and light is able to pass through, so it is well seen all around, and it is in the lumen the other way, unlike the calcific, lipidic, and fibrous plaque, which we see it in the wall. So you are going to see the abnormalities either in the lumen or in the wall, and this is a imaging after the stent being put, after the stent being healed. And the comparison between IVUS, what we can say is IVUS also is going to see the calcium, but there will be a deep acoustic shadowing behind the calcium, so we will not know the density of the calcium, whereas OCT will show exactly the density so that we can know how to prepare the calcium inside the coronary arteries. It is just a balloon preparation, or you need to do a rotablation, all that kind of a thing you can get to know. And once putting a stent, whether the stent is well opposed to the vessel wall, all that you can do. Without much wasting time, let me take you through quickly my case. This was a gentleman who had an angiogram in a nearby place called Tuticorin. The doctor traveled along with the case, not for me, for this particular technology, because it was a demanding case, because it was involving in a major artery where the artery was branching, so we could able to put a stent, and we could able to get in various steps of the stenting, and finally we were able to pass the light after the stent, and we will to precise, not only size the artery, precising the placement, and after the placement of the stent, we were able to know how safely and eloquently the stent has been placed. Thank you, Anando.